Right now, the way I manage my patients, you start with osimertinib, and then you treat them until progression. There are three types of progression. You can have a localized progression somewhere in the body, you can have a localized progression in the brain, or you can have more of a systemic progression. I currently do not stop osimertinib if my patient has a localized progression and is otherwise doing well, meaning not losing weight, not losing energy, not having new severe pain in more than one parts of the body. In that situation, I would just use local therapy to that progressing single lesion and continue on osimertinib, versus if the patient have a more of a systemic progression, meaning rapid growth in more than one site, then I would recommend doing a post-progression biopsy. I'll show the data of what we could find on a post-progression biopsies, but you can find a mutation called C797S, and that mutation potentially could resensitize your patient to first-generation EGFR tyrosine kinase inhibitors, and you can use osimertinib first and then use either gefitinib or erlotinib as a second line. I've seen BRAF mutations as a resistance to osimertinib, and I have successfully treated my patients with an approved BRAF combination of tyrosine kinase inhibitors. And I've seen MET amplification. I have tried using MET inhibitors for patients who develop MET amplifications. There are clinical trials. The clinical trial called Savannah is open in many institutions specifically for patients who develop resistance to osimertinib due to MET amplification, and they get a combination of osimertinib and savolitinib, which is a MET inhibitor.